Creo que comenzamos.
Right, we'll be starting, okay?
Muy buenas tardes para todos. Bienvenidos a este nuevo webinar titulado Innovaciones en el cuidado primario.
Welcome to this webinar, the primary health
Innovadores de atención primaria en salud.
elderly, and we're going to have this in this primary healthcare cycle that is sponsored
Soy Luis
by and Salud Derecho. I am Luis Gabriel
del Banco Mundial.
I am from the team of facilitators, the World Bank, and a professor of the
Reciban un saludo
in
muy
Rosario University here in Bogotá, Colombia. I would like to give you a cordial greeting to
América
just
Latina,
actually ask them from the different
y Europa.
countries of Colombia, Latin America, North America, and Europe. This webinar is being transmitted
Salud Derecho.
from
La sesión
the YouTube channel in Salud Derecho, and it will be recorded for
Salud
academic
Derecho.
purposes, and it will be queried on the website of Salud Derecho, which you will have access through the webpage www.saludderecho.com after your record, a place in which you will have information about
Atención
event
primaria.
publications, technical research,
Presentaciones y
primary health care, and the memories and the presentations of the past webinars. In the chat, we will be placing the link to Salud Derecho. The microphones will be activated
la mano
in the
para
final panel, time in which
Sin embargo,
you will be
desde ya
able to raise your
para que
hand
hagan
and
preguntas.
participate. However, from now, I would like to invite you to do questions and comments through Q&As that is actually in the lower bar or through
Anuncio que
the chat function in the Zoom. Likewise, I would like to mention that we will have simultaneous translation where you would have access to
inferior de Zoom.
the little globe that you have on the bottom bar. In respect of today's topic, I want to start first by telling you that according to data of the Ministry of Social Protection, between 1995 and 2020, the proportion of the elderly went from 6.9 to 13.8%. And we estimate that it will go beyond 16% by 2030. Colombia has a public policy of aging of 2022-2031 to guarantee adequate conditions for active, healthy aging and dignified elderly age, inequality, equity, and non-discrimination.
Los territorios del país.
Keeping in mind the territories of the country that try to adequate their own policies to the characteristics of the elderly and the economic and social aspects that determine broadly the process and the conditions of aging, as well as the offer of social services and health to be developed to satisfy properly everyone's needs. That's why in this seminar, we will know the experience and the implementation of the policy of aging in one of the territories of the country, and we will tackle it of the levels of care for geriatric patients in primary healthcare, as well as the experience of integral care to personnel who are elderly with cognitive problems, behavioral problems, and
Los centros más reconocidos de Colombia.
in one of the best recognized centers of Colombia. We'll have the plan of Alzheimer's of Quebec in Canada, which actually points to strengthening the capabilities of the services of primary care for the diagnosis, treatment, and follow-up, integral follow-up of the elderly with dementia, and also
sobre organización de servicios de atención
from McGill University and the Organization for Primary Care for patients with Alzheimer's. Finally, we'll present a very
Colombia, denominado
program
Cuidando,
from the National University
dirigido al fortalecimiento
called Caring for the Caretakers, and it actually strengthened to care and the competencies of those family cares for the people with chronic disease. Before I give over the mic to our guest speakers, I would like to invite Dr. Luis Efraín Fernando, the Secretary of Health for the province of Cundinamarca, who will give us some brief opening words. Dr. Fernandez is a medical surgeon of Bosque University, a specialist
la calidad en salud
management
y
in health and audit of quality of health and economies of health with around 30 years of experience in the health sector. And it is an honor to have you here. It's a pleasure to have you here. Doctor, the mic is all yours, sir.
Un saludo cordial
Good
a
afternoon
los
to all. A cordial greeting
un agradecimiento
to the
especial
speakers and a thanks, a special thanks to the corporation Salud Derecho and the World Bank for their invitation and
estar
It's a
acá.
pleasure to be here, and for the Secretary of Health in Cundinamarca and the Secretary of Public Health and the component of
El
aging
programa nuestro de salud pública
and
es
the
muy
elderly as a program of our public health. It's actually very gratifying to give the welcoming to all the assistant members and all the delegates that
y además
today
nos
with us. And aside from this, it actually we're together with a common interest, which is the common interest for elderly patients, the aging process and the concern,
el curso de
the
vida
demographic change of the pyramid of the populations and the life cycle and the length of life that we have extended, the longevity and the portion of that pyramid that the elderly is taking and the challenges that it has for the respective states, their care and the creativity that we must apply to have a great amount of actions and preventions. It is the elderly that with their experience and wisdom, they are the people who can actually connect the past, the present, and the future. And that is why, in respect of the changes of the world that have a quick aging in the developed countries as well as in the underdeveloped countries, we are being called, for those of us who practice governance in medicines, to generate some equilibrium measures in respect of great needs and high cost of population and having a greater portion of the pyramid income vulnerability being exposed to. Health players, governments, academia, society must reorient the health service to model based in of health with emphasis in primary health care. We must strengthen the social protection, the economic assurance, and we must strengthen the community participation of the elderly in their decision-making process, and we have to guarantee their rights and cater to their demands and needs. The redeciding of this health treatment and technologies and medicine respond to the needs of people, of the elderly, of the aging personnel, as well as the sector of public health that should be articulated with other fringe benefit sectors that actually can turn active aging to generate policies that are multi-sectorial for the quality of life of the elderly. Colombia has been a pioneer in issues of primary health care in health, and it is in vogue because in the so-called model of the reform that is now being discussed in Congress, we have been speaking of the entire model based on APSs, but I want to tell you that in Cundinamarca, we do primary health care a long time ago, and not in vain. All these topics of aging and the elderly are all included in all these APSs. It is policy of the province of Cundinamarca since the year 2019, the legislative body of the province that actually had the ordinance 093 of 2019, where the public policies call for active aging and happy aging, integral aging as of a policy as such. We have strengthened the programs, and in the current government that is about to, this 31st of December, the last 4 years of the governor's office, we have invested more than 5 billion pesos in aging policy and the health services, without counting that we only talk about aging in health, but actually we do it from the technical of social development of the elderly, the Culture Institute and Tourism Institute, from sports, from the Secretary of Government, from Secretary of Recreation, from the Institute of Public Services of Cundinamarca province. So it's a mainstream cross the board policy in terms of health and other things, other caring aspects that the aging population needs. And as Dr. Bernal was saying, the population pyramid has now changed in terms of percentage, and ever more with the given culture of not having a lot of kids or not having kids at all makes that our population ever more gets older and older. So I want to just say cordial greetings, and I leave you to get into the detail of what we're going to be told. I am accompanied here by Dr. Olga Chavarro, who is the reference person for the entire program of aging for the Secretary of Health that actually depends in turn for the public health department of our province of Cundinamarca. So once again, welcome and thank you very much for inviting us. Thank you, Dr. Efrain. Thank you very much for having me here, for being with us, for opening this event and putting in the frame this in this very instant and what you've pointed out, that definitely that the aging processes cannot be seen fragmented in terms of the health services and then another sector. Rather, it's the person that we must focus, and it must be mainstream across the board services as we cater to the needs in terms of social, economic, food security, and health. Of course, we are contributing to better well-being, a better quality of life, and what it will be represented in better results in the population, not starting from the age, the adult age, but rather from before the conception. We promote an active aging. So thank you very much for putting in framework of this event to a wholesome treatment of the issue, and we'll talk to Olga Lucia Chavarro about the details of the aging policy of the province of Cundinamarca. And Dr. Lucia is a professional of public health who will illustrate us in this respect of this policy that is projected since 2019 to 2029 and the main results that we obtained today. Dr. Olga Lucia is a bacteriologist and specialist in health management. Dr. Chavarro, please, the floor is all yours. Thank you very much, Dr. Luis. Welcome to all people connected. Likewise, for the guest speakers and for Dr. Robinson Cuadros, that we know him well. So thank you very much to the World Bank, this invitation, and this opportunity to comment what have been our progress in public policy. I'm going to share screen. Please go ahead. Right, thank you very much. As we were saying by Dr. Efrain Bernal, our public policy was approved by decrees in 2019 by decree of the department, and it goes to 2029. 1 minute, please. So that you can see a full screen now. So in order to put ourselves into context, those people who don't know our geography and don't know where the province of Cundinamarca is, it is located in the heart of Colombia, right in the heart of the territory, and it surrounds Bogota, which is the capital of Colombia, and it has mountains on the eastern side that generate our own identity in the territory. It's the eastern mountain range of the Andes that we have hot weather and cold weather, and we have a great diversity of population, and our diversity in having all these different thermal floors. The total population of the province, according to the last census, it's 3.5 million inhabitants without counting Bogota, because Bogota is not part of the province, of which 13% is elderly, of 460,000, of which 214,18 are men and 245,000 are women. The territory is distributed administratively and politically in 15 provinces and 116 municipalities, and according to the data of the data and the Cundinamarca territory, was the population concentrated in the main towns, and the 25 are rural communities. But when we speak of elderly, we speak that Cundinamarca in the municipalities that are remote and the far in countryside, they have a lot of elderly, because in the farm there's the younger population is the one that migrates to the population centers. Look in our pyramid, let's look at the red line. That was 2015 with a comparison, the blue line. In 2023, look how our populations are in everything that you have actually contextualized before. Just to say something and to have an idea of the decisions that we are making, let's see this data of CISPROTOMO of Cundinamarca, that for causes of mortality, the first cause of mortality is circulatory diseases, and we will see that there are many things that we can do there. In mobility, that we have that for the elderly older than 60, the highest bar is in non-transmissible diseases. There's a lot of things that we can also do, and this is how we had starting age to contextualize there so that we don't go into detail, and for us to go to the public policy that was built with citizens' participation, with institutional support, with the support of our colleagues in the component to whom I greet, and I take the become the spokesperson for them, and what we say of how policy has progressed, because without a team, there are no results. The purpose of this to guarantee from these people of the province in Cundinamarca the access to services and progress promoting active aging, a dignified aging process. And this policy was built four main strategies or four main axes to greater protection, greater participation, greater autonomy, and greater happiness. And for this, we can guarantee to the people, to all these axes one, and from the axis two, to be able to make them inclusive and people socially active, participating, and axis three, through greater activities to guarantee a physical environment, economic, a safe environment, and social support, and greater happiness, which is the end goal of all the people that are included in that are covering these stages, and of an administration that can see there a public policy under these aspects. We have to recognize, as was said before by our secretary, and what you have said, there is a new public policy of aging in the country with axes. One is surpassing economic independence of the elderly. Axis number two is social inclusion and citizen participation. And then the three is a life free of violence for the elderly. Axis of four is integral care and health, and to have other access to special care. Pillar number five is actually the healthy aging, and the sixth pillar is education, formation, research to face aging and the old age. And we have, this is the policy that was built prior to this date. It actually perfectly has, and it's related with the pillars that are proposed by the Ministry of Health. And at this time, they're actually having this adaptation process that is not difficult, because we have the different focuses. To tell you also that the public policy of aging, actually we work through the instances of these elderly people. There's 26 instances between secretariats, institutes, and other ones, as our secretary would say. And then we have this way in which we have this instance where we develop all that was proposed within the development plans, and they're going to be measuring their sales as we're going to see it next. So all of them participate in a very active and coordinated on the greater protection of all these pillars of goals of the results of the 10% of deformation that we have of that physical activity. And this is promoted by the Institute of Sports, the reduction of the prevalence of obesity in 21.96%, taken from the citizens food security and nutrition and the control of the situation, which is quite worrisome when you see that it's actually very much high level. It's worrisome, but with the that we have actually taken, we are actually placing some challenging goals and to have strategies so that these situations, that 60% of the elder population of Cundinamarca suffers from obesity. So that places new challenges and new intervention strategies, because these are solvable. Why do we have this promoting ones? And within the major axes, we have these healthy lifestyles approaches, and we have the Secretary of Health working on that, and we have an increase also that we have through the Secretary of Social Development, an increase of 8,700 slots to date. We have actually catered to 42,000 subsidies for the running of all these people. And also we actually began to increase the quota, especially on these increasing goals, and to increase and cover more population within this participation, more participation pillar, because we know this is quite large, but we're only taking here the most starting, and given the limits of time in this presentation, only to have these bulk concepts. So we retake some of them. We take the reduction of 8 of the type of violence that they suffer, that they have to increase, an increase of 2017 to 22 of 232 people that actually join education institutions that we're going to take as a model as a success story in the population of Cundinamarca, an increase of strategy in the municipalities of the province, promoting public policy from the work that they do as an aging, healthy aging, so that they adopt the national provincial policy, and we do that increase the methods and design of policies in all the municipalities. And as I was telling you, very nice, this example, very interesting, the formal education for adults that the Secretary of Education does it year in, year out, is guaranteed 121 openings in cycles in basic primary school and secondary schools, 80 people, 80 elderly persons who have been in the centers, and in the last cycle they had 17 students, 127, 87, and 117. The Secretariat of Education, this is an inclusive project. In other words, it's carried out by the very teachers that actually teach all the formal issues, and our elderly are learning hand in hand with the other people who are actually in the systems up until they're finished their last grade and the high school diploma. Is really of impact how these professionals in education this year they actually do their, and this as they have all this one, and they actually concur, and then they actually have the ones, and then we have, and it's very important that is in the public policy, they actually see us there as people who are there of rights, and then they have institutional ones, and they actually build and they certify there as any student, they compete, and they challenge each other in their primary and secondary education until they graduate and so on. This is a beautiful example and so on. They actually can increase it as the goal that we have proposed. Another of the ones that I actually had to highlight is the component of aging and so on. We had experiences like in all the countries in respect of the pandemic and these huge challenges to try to give responses to all the needs of all the elderly, and this made us come closer to the other organizational structures and the analysis and the needs of participation to try to find their needs and to realize that their people actually abandoned and we needed a solidarity system, and others were alone and vulnerable. So this actually gave and realized to some alerts of these experts that they were finding these ones in these conditions and these needs. They were alone. I mean, and this was there's something we had to have these contracts with the APSs, as Dr. Fernandez said, and then by doing the characterizations that we did, we saw that on this one we have there were some people alone, and that we were not able to identify them fully. And from APS, we were actually turning them visible. We articulated with APS the care systems, the models of some palliative care, and then to have a network that actually we did it by environment, by circles. We kind of joined to the 3280 that we do is a structure that they have of integral care that was given to them, and we took that model and we did the primary network that actually corresponds to the personnel with the participation of the different organizations. And as you saw, it was in the pandemic, and it was actually very nice, this school environment, because these were all volunteer ones. They were not obliged, but then they had the schools, and then they had the students, and they raised their hands and they became volunteers. And once they turned volunteers, we actually to the institution so that they actually could have it as a social work. But at the beginning, they were volunteers. And here you have a picture, and the elderly wanted the students to teach them to use a mobile phone because they had knowledge. They had the knowledge of reading, and then they had education level, and what they wanted at that level. They had that training for education, and they wanted to have these action plans with the elderly and so on. Another institutional was where the mayor's office and the people that work with the elderly, they have a greater handling and strategy for education for these aging persons in all the services. So they would go to all the nodes, and we also all the stereotypes and the working note. We did some articulation with some health and working opportunities to the informal elderly that in my municipality, many of them are informal workers. You find elderly people in the marketplace, the elderly selling things, people that are the kind of the core of the economy in the municipalities, and that structure give information to those who are being included as volunteers in the networks, so we will actually make them more sensitive in aging, in self-care, in practices, and in their environment. We try to strengthen the entire environment, and it gives them a roadmap so that they can have care and make them more sensitive. That it's actually a year plan, a 12-month plan, so that it doesn't fall that quickly. And important pathway, the key pathway was that those people had helped us to locate those people who were abandoned. They would report to their leader, and the leader would tell the mayor's office that actually coordinate, because this network in the end that actually did it out of public health, that it has that public health. The owners of those networks are the mayor's office. They have the jurisdiction, they have responsibilities of the budget, so if they left an elderly person alone, it is something that was a member would tell its leader. They would coordinate with the people that actually help with the health in each municipality, and they would do the collective intervention on this one at the same time. If they had a vulnerable right, they would add the routes with the commissioner of health, so that we can eliminate the violence against this elderly. If you have active nutrition, because they still have them working with the APVs, depending on what they found, but also they were able to generate their own solutions to awaken the solidarity in the community. And that way, we can have the different nodes and they can go to these different people. So we have proposals, and then we have like a merging, and we want to go help that person that was alone, because actually they had restituted their rights and they had no problem in coming close to them. And let's walk with them, and then we'll walk with the people in the municipality. The idea is awaken this solidarity and sensitivity in these conditions of vulnerability, aging, because as soon as they know that people care, that's how they best feel, and they would learn that. And then on the other side, we were not leaving those people to do their, or they're having spent the pandemic, they're do as large, because not all strategies are necessarily enough, because with the articulation with the model of the APS, and then we also have designed this within the APS strategy. So in the other RAMDO, we have greater autonomy that we have here to speak the decrease of 5% of the provincial intervention of 10% of the people who have productive projects. And this is very important because it gives them economic security and for them to start their own business, to be competitive. And the Secretary of Agriculture, that I'll show you in a minute, this was a sample that the organization that we did it with called Pensiones and with the Ministry of Labor is a matter of pride for the elderly to have this recognition and that scenario for their cultural activities of their entrepreneurships and their startups, where before having other form of this. It's actually very beautiful to see this aging person. They actually have quality seals and so on. They're there to show their products. And we did that in Corferias in Cundinamarca, which is a fair in Bogota. They participated in all those events, and they also have academic events. And it is something that with the Ministry of Labor encourages, and for Cundinamarca, it was a great opportunity to receive that support from the Secretary of Agriculture of the province. We have special programs for all vulnerable people. And here I have a chart of all the elderly that benefited during last year and all the productive projects, including what they were victims of the art, including people with disabilities, people who do farming activities. And what is beautiful about this, they give all the training, they are accompanied there, and they have all the raw materials that they to actually have their own produce and to be able to sell their own produce, and also the recognition of all the elderly that, as I told you, are very important in the small municipalities that we have. So good that the secretary of the province actually did it with all of them, because I cannot go into detail because of all time, but in respect of all the technology, the machinery, the raw materials, the fertilizers are all being invested so that the elderly can actually carry out their productive activities. And as we know, this is a sector that is a very farming province. 20% of the ones that were tied to the bank, the talent bank, and they would develop their talent in the Institute of Culture and Development for all the activities, including elderly, and also some day passes to a considerable number. Last year, it was for 1.8 billion pesos to go see touristic activities, the Sol Cathedral in the Nemocon Cathedral, and so municipalities that are close to Bogota, so they can do tourism for a total of 36,000 day passes, where the elderly receive refreshments, transport, the tickets, and they have time to see. And the ones who know around the world, they know far away from where they are, increases their perception of life, and is something that is satisfactory and of resting and integration and resocialization. The key factors in implementing the public policy and aging in 2017, I think there was some active integration. We consider that it is the participation of society in building and doing follow-up of this public policy, the institutional commitment for these elderly, and the execution of all the goals and the development plan, and the convincing of human talent to transform the quality of life of the elderly is what impacts the most. When even recovering through this public policy, it is how you do it from the different areas of the governor's office. People believe that it is possible to transform the lives of the elderly. Thank you very much to all of you for your attention. Thank you very much, Dr. Olga, for your intervention. It's very interesting experience of implementing this policy that actually allows us to visualize the results in terms of improvement in life conditions, and especially in the inclusion of the elderly in the province, because a good part of what we observe is that we kind of leave elderly behind. We don't involve them in the cultural everyday life activities and productivity activities of the respective communities, and that makes them that they feel alone, isolated, and they actually worsen their lives. And so your approach that is across the board is actually very important to safeguard the aging processes. So thank you very much, Dr. Olga. I'm now to give pass to the presentation of Dr. Carlos Cano with his chat, Levels of Care in Pediatrics. I looked at primary health care. Dr. Cano is a medical of Javeriana University, a pediatric doctor, graduated from the Complutense University in Spain. He's a guest professor and director of aging in Javeriana University, and aside from that, he's also chief of pediatrics of the San Ignacio Hospital in Bogota, Colombia. He created the Center of Memory and Cognition Interrectus of the same hospital, a senior investigator of science and technology in the Ministry of Science, and also the author of more than published 80 articles, and the president of executive of the Allen Institute, the OPS, or World Health Organization. And Doctor, thank you for being with us. Please go ahead. Here, Dr. Cano. Dr. Cano. Now, can you hear me? Yes, doctor. Now we can hear you. Yes, thank you. Can is the slide see is visible? Great, perfect. So thank you very much for the invitation. In this 15 minutes that I have, I'm going to transmit this task that for me is an important challenge to actually achieve. But of course, I expect that the message can be understood, and it is the importance for the care levels in pediatrics, because I mean, the elderly must have a place of care, be what it may in their individual situation, and of course, and look from the primary care, which is the goal here of this presentation. So we have already seen in this aging processes that we have, and remember that in very few time, in less than 20 years, we have gone from 7 to 14%, doubling the aging population of 65 in Europe and in France actually took more than 100 years. So we must be all too careful with our public policies, because we're going very fast in this situation. Colombia, since 2015 to 2025, practically is going to triple its aging population that are older than 65 with 28%. In 2050, it's going to be like that. And going into the subject matter, there are many health models in the world. And of course, these are models that are, let's just say, implemented in many countries. And we cannot say that one of them is the most adequate or the perfect one, because therefore we have one model can actually call of the British system, for example, that has been so much publicized, and so we know that it is a public system where we can say that generally, and for some time now, for several centuries, we have been implementing it in England and in Canada, where it is a state that covers the care of people. The US system is a totally different system where you have high technology and unlimited access to the systems. And this actually occurs in certain countries in the region, for example, in Latin America, we have systems of public mix, of private and public coverages, or equitable universal coverage that actually could be applied in Mexico, Argentina, Chile, or Ecuador, which are countries that are connected to us in this webinar, and somehow some other systems here in Colombia, we have a situation that is very specific. It is a care model in health that is mixed and actually is private and with public finance. They actually come from there. Then we have their public there. And then I have in one of the red that we have the subsidized ones and so on. And then we have there, we're going to send you the services here. And then we have public and private wings and institutions that then we have there. And then we have, the IPSs and then we there as such that we can have from juridical persons or a natural person. This is Ignacio helping. And then I want to mention that for many years, and they have the person there as a fundamental axis of what is the policy and the context and the orientation of our hospital and so on. And then let's just say it's a model. For us, it is fundamental. And then we have to be behind the ones that is centered on the problems. And then we have there the illnesses, and that has given us a view that is actually somehow different, and so on. In this way, in this same context, I would like to tell you, and then we have there of our moderator. I have to mention that the care in the person or the patient actually go from what the slide can say, could be the classical ones or the clinical ones, of community ones, that they are the families and not necessarily their health, that they actually can do they're actually in green. And that situation of integrating in this circle is actually the objective of each one of the systems that one can apply, where we know that people can be in a condition, in one condition or another, but independent of that, they would require assistance in any of these circumstances. The care levels that actually start from Mary Warren and so on in their levels that have actually done there, and they have done there to different sectors that we start from an area such that we talk about the conceptual ones, and then we have that adult one, and then we have a hospital be there or the community actually to be covered in any time, in any situation, as we see it summarized in this jurisdiction where there are the hospital level, and we have the level of acute ones who actually have more acute ones and so on, excuse me, we have these intellects and so on, and then we have the different axes here, as we're going to see here, and we're going to see the settlements and then something when you have home care and so on, they have greater relevance in the elderly and so on, and then have in rehabilitation and the long-term care. So we have managed in our center with some care levels that actually complete. We have everything that we've just done. We even have resource, a medical room of psychiatrists. We have 20 psychiatrists. Of them, we have in a service that is absolutely large, the greatest one that we have in the region, with 20 professionals there and 30 of pediatrics. And of course, we have an entire that it goes from psychiatrists, neuropsychiatrists, and so on, pediatrics, and so on, that I think that they actually cover a very important level. And this is a new series and so on. And then we have there in a center, and then we have there in this address, and then we have certainly for rehabilitation long stay. And then this is our reality of IPS, our hospital. How can we see this? How can we adapt this from the primary care? Here I would start with telling you of first care, and then it's impossible with the amount of directives that we have and the development that we have not only in Colombia, but in the great majority of countries in America, not to say all of them. Perhaps Mexico, they have a bit more progress, but nonetheless, we're actually trying to cover their form primary care. So, and then you directly here to have the assistance in this level, and then we have of the very primary care, and not in vain, it starts from this report of 2015 that actually we have the director, and then we have the organization there of health based on this book that we have there of health, and then we have of them, and then that actually should be there, that should have an implementation, that then we have there. And then we have their governance of a healthy aging. We have there, and this is an important message that we must keep in here. And then we have the I've been working with them. And I'm talking with the ICO. And this one, they were talking about integral care. They actually work with the primary care. And this one, that we have there with the city. We have the possibility of developing there. And I want to present it in a very brief manner as a model and as a system to be able to understand from primary care the possibility of understanding the elderly. And this is a key one to understand the proposal. And then here you have there, and then you have then we have, then we have to do that. But the intrinsic one of there, we have the ICO one and so on. And then we have there, and then we can have there the intrinsic one. And there are 5 elements that you can do there. And then you have clearly mentioned there, and you have there in the organization of the PAHO and the WHO, and there the ones that there we have the facilities and so on. There we have, and then the cyclical capacity of that is associated with them, with the aspect there and then the neurosensorial ones there, and the audition. Please eliminate the main speaker. You have to eliminate the main speaker, totally his voice, so they're there. And we can have there and detect and have an impact on the intrigue design of the medicine, of the evidence in the results that are clearly there so that you can maintain the functional capacity. And then you have there. And then we have audition there. The nutritional or effective one. And now I'm getting to the end of my presentation so that we can have questions. And then we have there in the proposal per se of the different steps, and those steps are 5 steps so that we can increase it there. So the first step that we can have, this entire proposal is in a primary team, not necessarily the first step there. It's not necessarily a doctor. It could be primary care is to understand the life of this elderly with the priorities and the context and the social context. And this is something that I can detect and actually detect. So we have to detect that, and this makes it like that at the component of the health team at the level, rural level and so on. And then you can do that a second step. There actually the evaluation center in there, and then we have in the primary care and this training, and then we have there that the OPS actually has that more than 36 doctors there in that it's called ACAPEL, and this ACAPEL, there are certain modules that we can take from the OPS or the World Health, the PAHO, I mean, so that they can give the second step, which is assessment. It's evaluation per state, and then the step is the making of a plan, a personalized care plan that actually goes to it, actually transcends the primary sector, and it can go further, including other type of services beyond there, which could be rehabilitation or the intervention in other type of circumstances that are more specialized, and it somehow transcends somehow the primary care. And one first step that is to guarantee the derivation and the follow-up of this care. If someone needs a or so on, they're going to raise their level of complexity so that they can get to a fifth step where you involve the community and the support to caregivers in a basic place to understand this icon proposal. I just made a very brief summary of one of the most successful results of medals in healthy aging that we have had. One of the greatest difficulties and greatest concern in this one that I was making reference to is actually given to the long-term care. Be what the age or the intrinsic capacity of which you have spoken of these elderly patients, they all want and suffer an important capacity, intrinsic capacity, elderly than 80 or 90 years old, where they have their intrinsic capacities are diminished, and those long-term care that at the end of the day should be an integration of the state, of the family, of the caretaker, of the services, so that we can have those people as main axes to be able to do some care to guarantee the survival and living conditions of each person at any level, at the care level. So with that, I would like to close and to give some final messages for all of you to remind you. One of them is that pediatric care of elderly patients must focus in the primary healthcare areas, and it's fundamental to understand this concept because it doesn't start from great specialists and great professionals, but just a team of primary healthcare officials that actually train in detecting the problem of the elderly. There is no perfect system, and we already saw that it doesn't say that there's no such perfect system. And currently in Colombia, they're having in a process, in a proposal of the reforms to health that very probably they have elements of what we have seen because they have done so, and especially the sectorization in primary care, and then the policy is based there on primary care, but it doesn't exist. And these strategies of the WHO and the PAHO can be a good starting point. The sectorization, I think that is a modality that's also known, and we in Colombia have not had the possibility of increasing it in certain regions. In certain regions, we have been successful, and possibly Cundinamarca is close to Bogotá. They do have the possibility to do so, of sectorizing and so on, but of course, it's something that we should keep in mind for our systems, for our proposals of care. of adult care of the primary sector, and the levels of care should fulfill certain criteria. For some of them, some specialized personnel, and of course, the pediatrics will always have a protagonic role in the side of formation or whatever it's needed in the specific care that we have proposed. So thank you very much for your invitation, and thank you very much for your attention. Dr. Cano, thank you very much. And you did an excellent job for all this time and to communicate this very important message that also is very much the experience having Colombian, and that first step that illustrated all too well, which is where modify those life conditions that facilitate living, healthy aging, and from there we derive, or they should be integrated to other levels of primary care as of the basic ones, and so on. They mentioned that to a good level they can absorb an important number of activities to preserve functionality and to maintain, incorporate the person in its daily life to their family and so on. So I think that much of this we're going to continue visualizing what Dr. Howard has actually mentioned from McGill University is going to share with us, where these basic themes actually place in practice, and they can do it in how they did it in the province of Quebec with the presence of multiple specialist family doctors. And I want to thank you very much, Dr. Cano, for your presentation. And with that, I'd like to welcome Dr. Howard, please. The mic is all yours. He's the vice dean and a medical family medicine, pediatrics, oncology, and so on. And then we have there from McGill in Canada. And Dr. Howard is the fellow of the Canadian situation there of the medical doctors and the surgeons institute there, Canada. Then we have us there, and then we have it there, and then we have the primary care and then we have chronic illnesses, and then we have more than 165 publications of reviewed by peers, and many ones are there. And we actually speak there of the Quebec ones of 2009. And he is working now in the implementation, and he co-created and co-directed the Canadian team of health and improves the system in dementia. The ROSA groups that actually dedicate to the directed was primary care to diagnose and to treat Alzheimer's and their caretakers. Now we actually receive the ones of Canada and the international level, thanks to their contribution and to the development of family medicine and the treatment with the cognitive disorder. In 2021, he was named as 24 members of the World Council on Dementia. Before having over the mic, I want to invite the participants so they formulate their and then we questions and so on. And then we have to comment and so on. They have theirs. For us, it's another, Dr. Redman, to have you here. And please, the mic is all yours.
Hello. Buenas tardes or buenas noches for you. I'm sorry I won't be able to speak in Spanish, but I'll speak in English. I'll try not to speak too quickly. It is an honor for me to speak in this seminar, and I want to say hello to my long-time friend and colleague Carlos Canos, and to my colleague and friend Luis Bernal, and to other colleagues perhaps that I've met over time. I remember going to Colombia in the 1990s, and I can see since that time really the improvement and development of the healthcare system in general and care for the elderly in particular. So I'm going to start now and talk to you about some of the policy lessons of the implementation of the Quebec Alzheimer plan. Just a quick note, the Quebec, the Canadian system is a federal system. We have national principles, but it's really the provinces that manage the healthcare system, and that's where the importance of the provincial plans rather than the national plans. Quebec, our plan was adopted in 2009, implementation is 2011, and there are various other development of plans in other provinces when the approaches are basically similar. Primary care is seen as the way forward for a very, very long time. Since 1989, when we had the first Canadian Consensus Conference on dementia, primary care is seen as the first contact, has patient and family longitudinal experience, and is probably the best trained and equipped for community older persons with multimorbidity. And there'll never be enough specialists interested and trained in Alzheimer's and memory clinics. And there's not evidence that memory clinics are more effective in managing dementia. It's possible now, particularly in Canada, and I can see the development of primary medical care reform. I was very much involved in my province in the establishment of what we call the family medicine groups, or Groupe de Médecine de Famille, which are group practices, team-based, interdisciplinary, where we now have nurses, nurse clinicians, nurse practitioners, and we have recently added social workers and pharmacists. And a key aspect to the family medicine groups and the primary care in general is continuity of care. And it's been shown that continuity of care leads to lower costs, lower emergency room use, less hospitalization, less mortality, and improved quality. And Claire Godard-Sibliet from our group published a very interesting paper in JAGS showing that. And so the Quebec Alzheimer's Plan, the minister asked me to lead the task force to create the plan in 2009. By the way, we're now in the process of putting together a group to refresh the plan, because it was first written in 2009, so it's time for refreshing the plan. These are the 7 priority actions with 24 recommendations. I'm going to concentrate my remarks today on the second priority action, on access to personalized coordinated assessment and treatment services. And so probably like your country, like in many countries, there's poor access to diagnosis and treatment, and poor access to integrated management. Memory clinics can't handle the volume nor assure comprehensive continuity of care, resulting in long waiting lists, delayed diagnosis, and late intervention. I co-founded and co-led for many years a tertiary care memory clinic at the McGill University, and it was the best memory clinic in the world, except it took 8 to 12 months to get in, so it may have been the best in the world, but not very useful. And on the other hand, primary care was generally not prepared to deal with patients with Alzheimer's disease and related disorders, and so many patients are not diagnosed or diagnosed late. And so our objective was to provide rapid access to assessment and management, and personalized management, innovative access through a trusting relationship between patient, family, and a credible clinician. So this notion of personalized access to a flexible range of primary care and community, as well as specialized services. And so anchored in primary care, and the key objective is a patient-oriented and not a disease-oriented approach, enable and empower the family medicine group primary care clinician, so the physician as well as the nurse and now social worker and pharmacist, to detect, diagnose, and treat the vast majority of patients with Alzheimer's disease. And this is the basic approach. It's not very original. It's the collaborative chronic care management approach based on the partnership of a patient-centered approach, not disease-centered, by patients treating a partnership with the physician, nurse, etc., with the patient and caregiver. So we had to see, is it the diabetes model or the cancer model? The cancer model, as soon as somebody in primary care sees somebody with cancer, they're sent to oncology, and oncology takes over. Diabetes model, 80% of diabetes in my country is managed in primary care, and endocrinologists are used for the complex cases. And we turn to the diabetes model for the reasons I gave. So some of the key messages from a policy point of view were, number one, there was a ministerial decision that the Quebec Alzheimer's Plan is a priority, a ministerial decision. And two, there was it was modest, but a recurrent budget. In other words, a budget each year, a very small budget compared to perhaps the whole budget. The second policy decision is that the minister made was it's going to be anchored in primary care, based, as I said, on a person-centered approach and enabling and empowering the patient's primary care family medicine group team to be able to detect and manage Alzheimer's disease, the vast majority. The next and very important point is that there was an implementation plan with an ambition change management strategy with associated funding. The ministry didn't restrict its role, saying, as they often do, here's the policy, implement it, we'll watch you. The ministry was actively engaged in inspiring, stimulating, and supporting change, ministerial leadership with inclusive stakeholder governance, and diversity in application. So one size does not fit all. How would we apply it in the biggest city in Quebec, Montreal, with the general population of 4 million or so, would not be the same as in a rural area or in a very outlying region. This next very important point is integrating research. So research right from the beginning was integrated in evaluating each step of the implementation of the plan, feeding back to the ministry and the clinical sites. And finally, a sequential approach to implementation of 3 phases. And I'm going to try and explain what we mean by that. And so in 2009, the plan is tabled. 2011, a ministerial decision to go ahead. 2011-12, a pre-implementation phase. Then phase 1 with targeted implementation with independent peer review evaluation to improve and scale up. So implementation projects in 40 family medicine groups, urban, rural, remote, chosen by competition. And so that allowed us to learn from this initial implementation in order to improve and then to scale up, which was the objective in phase 2. And now in phase 3, of course, we're post-COVID and everything has to be restarted in many ways, but the emphasis will be put on transition and behavioral manifestations. So initial implementation, as I said, there was a pre-implementation study and consultation with clinicians. There was a mobilization of clinical champions, capacity building strategies, the development and dissemination of clinical tools, commitment of university partners, and the engagement of 4 project managers to support implementation. And so there was evaluation of the implementation of the plan by the ROSA group. I can't go through this in any detail, but just to say that it was using both quantitative and qualitative methods. Baseline, very interesting. We were surprised and pleasantly surprised to see that the clinical knowledge of clinicians, of the physicians, was actually quite good. And there were positive attitudes toward the disease and toward the Alzheimer plan. They strongly appreciated, supported the use of the interdisciplinary approach and access to physician and nurse expertise within the family medicine groups. Although received late, people appreciated, the clinicians appreciated the pathways and guidelines and training, as well as access to outside expertise. And they were critical still about the delay to access memory clinics and home care. And so some of the key results of this first phase was that it's feasible. Primary care can detect, diagnose, manage, and meet the needs of persons living with dementia and their caregivers. And a person-centered interdisciplinary approach by the patient's treating physician and clinical team resulted in improved continuity of care, higher intensity of follow-up, improved quality care, fewer but more appropriate specialist referrals, and decreased emergency department visits and decreased hospitalization, and room for improvement with antipsychotic prescriptions, evaluation of caregiver needs, and referral to community services. There remain significant challenges, and the first is generalization, is going beyond the initial innovators, leaders, and champions. And still working on the mobilization and buy-in from the physicians in the trenches, the primary care physicians. The second important challenge is transitions from family medicine groups to home care, different approaches, difficulty of communicating information, the challenge of behavior manifestation, the role of persons living with dementia and their caregivers. And I want to insist upon the advent of biomarkers and disease-modifying medications. You're hearing more and more about it, and you're going to hear more about it. It's probably going to result in the most important challenge to equity and access to care. There's a real danger that these very expensive, high-tech, requiring a very high-tech platforms is going to could mean that only the few who live close to university hospitals and have sufficient funds will have access to these treatments. And it's a real challenge. Medically assisted dying, which is a discussion in my country, and finally how we get out of post-COVID. So just some key elements that we've learned for successful implementation is number one, clear ministerial decision, and the integration into the ministry programming. So we weren't, we're in our 12th or 13th year of implementation, and it doesn't depend on which minister is in power, which government is in power, because it's part of the ministry programming and it's a recurring budget. Number two, having an implementation plan with priorities, with the change management strategy, accepting diversity in application, and phased implementation. Ministerial leadership with inclusive stakeholder governance, what we call credible extra-ministerial clinical leadership. And I think you have it as with Carlos Canos in Colombia and other leaders I know in Latin America, leaders who are not integral part of the ministry, work with ministry, mobilization of clinician champions, and mobilizing university and civil society leaders. Guidelines are necessary. Guidelines are relatively simple. The real issue, the real challenge is clinical pathways. How do we apply it in real life? Training and our ability to get into the trenches, and independent evaluation to support and adapt implementation. So I'm going to stop there, acknowledge my colleagues, and muchas gracias, merci, thank you very much. And I'm happy for the organizers to share my slides with you, and you can look at some of the documents that the links on these documents. Thank you very much, and I hope I've respected my time. Thank you. I'm looking forward to our discussion together. Again, thank you for the honor of inviting me to this seminar.
El honor ha sido nuestro, Dr. Howard, por habernos compartido esta experiencia tan
Dr.
interesante.
Howard, thank you very much for having shared this such an interesting experience. Definitively, what Dr. Howard shared with us is all aligned with what Dr. Cano mentioned, and the experience in Cundinamarca showed us we need to reorient the health services to care for the needs of the people. Now we have to rethink, as Dr. Howard tells us, how we provide those services. How do we have multidisciplinary teams that are not necessarily doctors to make them the most efficient possible, considering the limitations of resources that we have, the formation that actually has to be adequate to generate the competencies of these profile and technical ones to set up those basic primary teams that actually service this growing percentage of population of elderly that are going to demand more and more from the health sector. And definitively we need, aside from that additional change, we require a cultural change, as Dr. Howard expressed it, so that we can all understand from this need to do the transformation in such a way that we offer the services to the elderly. Thank you again, Dr. Howard. In our last guest speaker, Sonia Carreña, a nurse specialist in preventing ill treatment of the children, magister in nursing, and associate professor, National University of Colombia, coordinator of Latin America of Sigma Theta International. I'm the president of the Epsilon Nu of the Sigma Theta 2 International, life member of the International Association for Hospice and Palliative Care, researcher of the group of caring for the chronic patient, and senior researcher of the Science Ministry of Colombia. And she has had many articles published. There's 1 book and 6 chapter books. She is a coordinator of the network, caring for the chronic patient and crony from, and coordinator of the caring for the caretakers that we'll have there through its chat, taking care of the caretakers and so on. There we have innovation here, health, and there we have there. And with a lot of attention, we will listen to you. Thank you. Thank you very much, Luis, for the introduction. I'd like to present a special greeting to all. And well, okay, I'm going to share this experience of caring in this university, caring for the caretakers. And this is our flagship program for the National University of Colombia. We're a group of nurses, in essence, caretakers. Of what I'm going to talk to you about is part of the research ones, and there we have there in the university jointly with Dr. Chaparro Diaz. And first thing I want to ask is, where does this come from? Why innovate for caregivers? So our program is caring for the caregivers, but actually the majority are caregivers. So the first thing that we have to emphasize here in this afternoon, because an innovation here, we have an innovative process here, we have a need that is not satisfied jointly with the intent of satisfying it. And when we go back to our research of the group of healthcare, we find that our caregivers have many needs, among which we have their to recognize that they're caregivers and to accept their roles as caregivers, and that they need support, they need training, they need recognition, and they need relief. So I bring you certain of our studies, and they're the most recent one in 2021, a study with 222 of caregivers with pluripathologies, something that actually drew attention in our study. Before, we used to speak of caregivers with chronic disease, but today we're actually finding that our reality is that our elderly are having pluripathologies or multimorbidity. And when we value the different variables, like the overburden on the caregiver and the acceptance of this one that we have in the National University of Colombia, we actually find that our caregivers actually reported an intense care, and they report some basic levels of their role. So this actually says there, and then we have there, and then we have there, and then we have there, and we did there, and then we have there a people that we just changed it, and then we actually value their levels, and then we have there to actually have the role of caregivers and so on. And we find that the 60% had basic ones of their role, and only 38% had satisfied levels of them. So then we have there, and then we have and there, and then we have a matter of anguish that we did with the HAPS scale of anxiety. And we found that 44% of our caregivers apparently had a clinical pathology of anxiety. We did with that same scale, we actually measured depression with 22% placed in the clinical ones and 25% in limits, or dubious limits of depression. And additionally to this, a variable that we have there, that many of them that they had mentioned there, not only to them in their caregivers, we found that actually 41% of them, they actually had moderate loneliness, and 8% had severe loneliness. We did a regression model. We found that with the variables of depression there, we found that anxiety was predicting depression, and that those caregivers that had basic levels of accepting their role, of performing their roles there, they had greater scores in the scales of depression. And likewise, they had those that actually had greater scores. They had greater scores of depression. And likewise, their own variable of their exercise is those that dedicated a lot more time in daily activities to care for them, they actually had greater scores of depression. And that showed us there some urgent needs, or at least in terms of rotating them, giving some relief, and the term of preparation that we must develop with caregivers or family caregivers in terms of phasing their variables and scores. Aside from that, we had a different construct that was more specific. In a task that we had there, we did it all the time to promote the administration in their home, and we have an instrument to value this level of ability or adopting their medication in the home. And in a study with 320 caregivers, in 2021, we found that the majority of those caregivers had a level of basic ones of their role in their use of medication. This is a particularly worrisome finding because, as we commented before, the majority of these elderly ones, they have problems of pluripathologies, or they're polymedicated, and the use of mixed medications is actually one of those skills par excellence they must develop in their caregivers. Then we go to see from a broad panorama of needs. I cannot extend very much, but we have multiple research where we have mapped the needs of our caregivers, at least of the central area of Colombia, and we can now speak of how we can develop some innovation with and for our caregivers. The first thing that we have to, this innovation comes up with a cumulative process of experiences. And here we have a university experience research. We have done theses, books, written articles. We have a research, a seed startups. We have done consulting jobs of implementing our program in different institutions that provide health services. We have now had 17 years of implementing our program at the university, of which we have received 2 national prizes, 1 international prize, and we have accompanied the construct of 2 bills so that you can have a law for the caregivers in a situation of dependence. Regrettably, these 2 bills, so far the political moment that our country has, and of course the economic moment, they didn't pass for the president to sign the bill. And we have all the will and the evidence to continue to push these legislative initiatives. We have a network of researchers, and we have a registered trademark in caring for the caregiver. Why do we care, or with whom do we care for the caregivers, and with whom do we develop this innovation? Well, social innovations are socialist in their end goals as well as in their means. We work in our research labs. They're the people's what people? Well, as you can see here in the photography, we have students, not only of nursing, we have students of other faculties, we have our caregivers, our teachers, our researchers, and we also have our expert caregivers. And throughout these 17 years of experience, we have managed to consolidate the group of experts that they, in certain levels of formation, they actually take care of training their own peers. Throughout these years, we have more than 3,000 trained ones, and we have implemented the ones of the 20 ones of Bogota, particularly in the DIA centers, and including the Sumapas, which is the rural area of our capital city of Bogota. And we have actually managed to implement it in 3 health sectors, 1 at the national level. As we can see here, it's an innovation. It's not on products, it's actually on processes. And what processes do we do? To articulate our processes, all research teams and our extension teams and our teaching teams, they all point towards caring for the caregiver. We articulate our program with the Latin American network, with our planning seeds, and of course there with our research group. And that is how we have done with this research sort of startup groups. We have a startup there, a postgraduate ones that we're also receiving. There's the ones that we have there, and the ones that we have had at the level of the doctorate treatment. And this time, we're very happy to tell you that we have just started our mentoring process where the members of startup there, so we have students of doctorate programs, coach students of master's programs, the students of master's program, coach undergrad programs and so on, and they do mentoring, not only this startup there, but also in our program of caring for the caregiver. Currently, we have 27 research notes having evidence these care for the caregiver, 1 in Mexico, 1 in Guatemala, 3 in Mexico, 4 in Brazil, and we are qualifying in A1 in the Ministry of Science. We have 4 senior researchers, and right now we have more than 200 publications that are scientific evidence for which to do decision making in respect of taking decisions of caring for the caregiver. And it's during crisis when innovation flourishes. And here the innovations are relevant in these contexts. And here, logically, in the pandemic, we had a very important growth curve with our program caring for the caregivers, and we migrated to a hybrid modality. Practically 1 week after the COVID coming to Colombia, we actually were caring for the caregiver virtually in our YouTube channel, and it means caring for the caregiver. And we have at this time 161 live ones that we can reproduce in deferred one at any point in time. And we have developed 68 ones since the pandemic started. And every Tuesday, we have 150 participants. I disconnected there. I actually disconnect from here and go for the caregiver session. We have all Tuesdays at 6 p.m. we do have there, and we have views, we have had many hits and participation of different parts of Latin America. What have been the impacts of this innovation? Well, we have done implementation in caregivers with children with cancer with the Oncology Institute. And then we have here in experimental study with an experimental group in control when we offer caring for the caregiver. The caregivers actually improve the way they face there, they improve their knowledge, they improve their experience, their for decision making and for solving problems to activate their social networks and so on. They also improve their capacity to plan their life project. Also, another implementation that we did with caregivers, with children with cancer, is we found that by caring for the caregiver, we improve their well-being, we improve their instrumental capacities that they have for giving the physical care. They actually could anticipate in a better way the needs of children, and logically, they actually improve their level of support. In the study that we did with 329 caregivers with chronic conditions, in this case, adults in the city of Cúcuta, Sanguila, Bogota, we found that as a result of caring for the caregivers, these caregivers improved their skills to care, and they improved also the burden on the caregiver. So we found that definitively, it's been shown that whenever we offer support programs to the caregiver, definitively their variables, their results improve. And other impacts that we have had, we have developed a theoretical approach to adopting the role of the caregiver with chronic ones. And we understand that by turning themselves into caregivers is a transition. And I take the words of Dr. Howard when we talk about transitions, when he talked about roles, is not simply more tasks that we take, it's actually a new role that we take, and therefore requires multidisciplinary approach. We agree. We have had clinical programs in these palliative care units, finding that with these interventions, we diminish the uncertainty in the illness and we improve the quality of life. Also, we have proposed 2 instruments, one to assess the transition to the role of the caregiver, another one to assess the level of the caregiver in providing medication at home, and many other instruments of measurement in results in caregiver, the Scala UCLA, the UCLA scale that actually have validated for a Colombian context, and also the scale of uncertainty in respect of the illness. So we also have it validated in the Colombian context. We have done a very important effort to have with what make objective what happens to caregivers. And I think that now we have such a will to assess and to diagnose that we can actually use these contributions that we have done from academia in the territories. Final comments. This is a piece that we did jointly with our caregivers for the 24th of July, which is the day we commemorate in Colombia, the Day of Family Caregivers. to be a caregiver is actually to know yourself, to be a subject of care, that you join two paths and harmonize it, to intervene in multidimensional needs, to enjoy the role and the dimension and the magnitude, to love with limits and priorities, define priorities and delegate responsibility, and also to organize and optimize the resources of support to re-signify the role of the caregiver, so it doesn't become a suffering, but actually a life experience jointly that allows us to grow personally. Well, finally, I want to share with you our contact points. People who wish to be part of our group of caring for the caregivers, you can write through our email, and simply just by having access to any electronic device that you have the time in the afternoons, you actually can join our program and begin to be part of this community of caring the caregiver. Thank you very much for your care and, of course, for the invitation. We're very thankful for your participation. It's very interesting what you have said, especially because you have been measuring the results, assessing the results with impressive rigor that definitively, I think that you have been using it to back the need of having forms and guidelines, technical guidelines, seriously grounded on research and on data, so that we can have a healthy aging process and not only oriented to the care that we provide to the patient, but actually to the caregiver. Otherwise, the quality of the one who needs the care is not good if the caregiver doesn't have this. And well, at this time, I wish to introduce Robinson Juarez, who will be the moderator of the discussion panel, and Dr. Juarez is a pediatric doctor, a former president of the Pediatry on the human rights of the elderly in the International Association of Heritology and Geriatrics, and he has his opinions associated with the imaginaries and stereotypes in aging and in the elderly, as well as the integral models caring for the elderly. And he's a scientific researcher of Alzheimer's Colombia, and he's part of the National University. He's an associate professor of geriatrics at the Javeriana University and the Savannah University, and he's as a geriatric in consultant for aging of the Secretary of Integral Social of the Capital District of Bogota and in the Office of Social of the Public Health of Colombia. Dr. Mentinguez, he's actually of the Social Sanitary Ones of the Elderly in CAFAM and IPS in a service for the health in Colombia, and a member of the World Coalition of the International Federation of Aging. I'll leave you with Dr. Robinson, who's going to lead the panel. Thank you, Dr. Luis Garniz. Thank you very much for this venue that the World Bank and Salud Derecho allows us to speak about all these innovative models of primary health care. Listening to each one of the guest speakers, what first thing that comes to one's mind is all the things that we can do for the elderly now. We want to have that same care when we get there. In this new reality that we are facing as a country, that we're aging, that generates great opportunities, it also has challenges in pathways, strategies that are humanized and centered in the primary care and the elderly within the framework, clearly, of the Sustainable Agenda of 2030 in the decade of the aging there, proposed there by the World Health Organization 2030, and commitments that we have as a country, as well as several ones in our country when, in respect of the UN, we actually adhere and ratify the Human Rights Convention for the elderly. In our case in particular, we territorialize with the recent update of the Colombian policy on aging and the elderly. So I would like to propose a couple of questions to each one of the guest speakers today. And I would like to start with Dr. Fernandez, who gave us a great important opening. So Dr. Fernandez, according to what you've heard, how do we establish a sanitary health ones, but that is more integral? We see when healthy aging, every secretariat of each mayor's office works as they see fit, and there's not a joint. So how do we make sure that good actions transcend the current incumbent government. Dr. Fernandez, did you hear the question? Having some connection problems. If you want, I can. Of course, Olga, yes. Yes, the urgent from the World Health Organization is carry out intersectorial actions. Let's articulate, let's generate, that enables to generate and have a greater impact. And as we said, it's not easy. It's not easy because we're many here that are helpful. There are many topics, but however, I have a strategy that perhaps what you'd like to highlight is school environments that have healthy feeding, that is actually integrating the commitment of all institutions of the different government, the governors, and actually forces each municipality that at each school we give healthy food. It's all the educational community, teachers, students, and so on, of the economists, the stores that provide the raw cooking materials and produce. Well, that actually has tied 57 schools. And now we're trying to encompass more schools to have the goal as a food security policy. It's a good example of what healthy life can be for the next period. So maybe you can copy that strategy because it has several work lines and it seeks the school environment and family environment not be exogenous, but rather be healthy food in that environment. To develop that strategy, to actually have a food committee of healthy foods, so that we can have the educational community, so they have the problem with excess weight in the educational communities. So they did some training sessions with the entire community in terms of healthy food, in terms of the types of food that have to be provided in their respective physical activity, hydration with water, training the store owners in what is healthy food in respect of ultra-processed foods, so that you don't sell, sweets and ultra-processed soft drinks and you avoid the publicity of these ultra-processed goods, no advertisement of soft drinks and these ultra-processed foods, so that we have these companies that don't participate, but they're, and some commemorative days, the day of vegetables, the day of fruits, the day of juices, and so on, so that we have these school sessions to give style and proper feeding. And we have had institutions with traffic breakers drawing attention to what is a healthy lifestyle, and food baskets that they actually give them for teachers and for students. We have actually given water fountains for different types, because we have potable water, because there's some places where we can provide, implementing greenhouses in the schools, so that you have farming experts and hiring chefs, improve the cooking in charge and led by nutritionists, where we change the policy with the decree, so that this would become a norm and law for Cundinamarca in the educational environment. And this, as you can see, are helping us to generate different lifestyles that are healthy lifestyle for the youngsters, for adolescents, therefore for the home, and that way we will impact the family, professors, and the agent. As I was telling you at the beginning, we have a high 50% of the elderly are overweight, so this is impacting the situation that we're finding. Very interesting work that is being developed from the dimension and the policies that we have of the food policy, that we have our nutrition environment. So how do we mediate this, and how do we assess that? And we're training teachers so that they can have these assessments at least once a year to have a control on the effects that this strategy is going to have in this environment. That could be one mainstream board issue that can actually have in all the municipalities that are so critical, like Suacha, which is a municipality very close to Bogota, but it's one of the highest indexes of poverty in Colombia. So then we have Dr. Fernandez de Elizabeth. So there are many examples of multi-sectoral to follow the WHO's environment and how to tackle this. First, Dr. Fernandez. Good afternoon, and those commenting to us a bit of all the strategy that Cundinamarca has in cross-the-board lines in the different life cycle with very significant results on the promotion of healthy aging. But we were making a very complex question from the important position as the Secretary of Health, as the decision maker, and to be at the head of a multi-sectorial, multidisciplinary dialogue. How do you establish a social sanitary system that is more integral when speaking precisely of all this, all the health styles? Because at times we notice that each secretariat works separately the topic, and then we have like a clash of face-to-face trains that actually harms the good intents that actually enable to transcend each government. Sometimes you have a good plan, change the secretary, you change, and the plan is finished, and the new government comes in. So what sort of strategy would you be able to tell us to be able to strengthen further this topic? Well, above all, political will. In our case, in Cundinamarca, we have been able to progress in working across the board, mainstream, because Nicolas Garcia Bustos has actually given us the tools, has actually set that goal that as the director of the orchestra of our province government would put all our secretariats to work together. There is no government that articulates one another when the ministers of the secretaries, according to national government and provincial government, if they each work on their own without the boss, the president, or the governor, the executive at any rate, does not have a clear goal. In this case, I think that the successful experience has been as a result of the within the development plan and as public policies clearly been established. Certain programs, in this case, we're talking about aging and old age, and that has enabled that others are implemented or actually grooves to that machine, which is the provincial government. Definitively, I mean, the efforts that are across the board efforts, mainstream efforts that encompass everything that is one institution, in this case, the governor's office, then it works, and the rest are just stakeholders of each sector that we all contribute. But if the boss doesn't have the political, it's going to be very difficult. That's why nationally, there has to be a clear decision by the President of the Republic at the state level or provincial level. You have to have a clear decision by the government. And the rest, and obviously that decision is actually tied to budgets, because we could all have lots of good intents, but if there are no resources to do the programs, well, it's not going to work. So whenever we do the planning, then we do the development plans for them for the 4-year terms for these case of governorships. Well, one must project, plan very well the resources that are for each program, so that way we can establish and gather at the end of each term results. Thank you, Dr. Carlos Cano. Considering that in Colombia, there is a limited number specializing in pediatrics, what characteristics should these primary healthcare teams have? What capabilities must they develop to improve the care in so many elderly persons and with so diverse characteristics that we have in our country? Right, so yes, well, truly, let's just say that here we don't have to discover any different from what we were historically. I mean, in the cities, we have very variegated characteristics, the rural characteristics. So I think that the feeling And the setup of a team is actually very diverse. So I think it doesn't need always to speak of professionals, but actually of people that at some point in time, each country would be different. Some people would be health promoters or leaders in the social work or community work that actually can exercise those roles. So that's why the proposal by ICON is actually geared to people, to human resources, and not necessarily to professionals, because we know those limitations. So I think that in those steps, in those, the ones that you have to develop within the proposal of care, the integrated care in the adults, we must include all those that actually have in one way or another that connection with the community and with the social leadership. And in this, we have to think of caregivers in the family and in people who want to care there within own urban community and rural community. And I think that that setup is historic. And I think that in each one of our countries that we have done there, and we have had very similar developments, and simply it's actually to take them to that level. And then we have there in those characteristics, and then we have with the velocity in their time. And then we actually mentioned very tangentially, the OPS is actually developing certain courses, these courses on formal education that lead to a certification that we have there. And these ACAPEN courses go in modules, and the goals are of primary healthcare. And I think that they're important now that we actually can use it for any person that is interested in developing them and acquire those capabilities and develop. So I think that the geriatric doctors have other roles, other places where we can be protagonists, but of course in primary healthcare, it's actually the health primary care there who should be strengthened. And perhaps we can coach very much and collaborate their training, their pathway, the way of having access to that formation, but they're geared towards having that protagonism from the very center of where people, the elderly live. Right, that's right, Dr. Cameron. Totally agree. And I think that this is teamwork where the different assistant model, we actually work with different professionals, and also impact in policy, in public policy, and where we invest in resources to be able to result and have all these innovative projects that we have presented today. There are many questions for Dr. Carreño. Let's just say that caregivers is something that just touches our most sensitive fibers within our families, no? Based on the experience of the program, caring for caregivers, would you consider pertinent that the health system per se and the social workers of the state provide coverage for activities to care for caregivers? What would those activities be, and what services should we give priority to caregivers? As a matter of fact, as was commented there, we have actually had scientific evidence to form the proposal or the initiative of those bills to recognize caregivers. When we started to think in people initially with chronic diseases, we did not have the view of caregivers, but the very elderly, sick people says, look, my caregiver is more sick than I. Caring is something that gets tired. It's a human task. It's not an ultra specialized way, but it's a task that somehow requires that support and transition. Many of our caregivers are isolated, overburdened, not supported, not recognized, and of course require intervention by the state. We believe that care should be a family responsibility, or family, the family are not new, and we don't have an array of options who are going to be the caregivers. In Colombia today, the phenomena of caregiving is very family, not so state-based, in spite of the scientific evidence that we have, is a phenomena that is not fully studied. And yes, we require definitively a state intervention response. There's some district initiatives by the municipality. We are doing by the thought center or the think tanks. District care, we think that there we have very important ones to recognize, to alleviate, to reduce the amount of hours that dedicate to take care of it. But we also believe that it's important to articulate not only something of the health sector, but of course we are nurses. We are from the health sector, but I think that this should be integrated of all sectors, as was mentioned by Chavarro. It is important to integrate schools, teachers in general, community at large. We have worked also something that is very relevant in the environment, and it is the network of community care. Definitely, here we have the care should not be ultra specialized because then we will not have solve-based thing. It should be something that should have resources in each community, in each home, in each school, in each sector. So we believe that to develop these capabilities at the community level, use and articulate the social assets in health and social in each one of the sectors, and of course, to integrate, as Dr. Howard said, to integrate academia, evidence-based data, because sometimes import initiatives, we have good intentions, but we don't know very well what is happening in each of these environments. So we are marveled every time that we run some research with a giver that we know for a very long time now. And we see how each time their situation is changed and how we're discovering new variable interest to intervene with them. So we think that there should be a continuum of research, integration of decision-making, and of course, integration with the community, and also important to involve caregivers as leaders to develop processes of expert caregivers. They are more than willing to teach what they have learned from their experience for years. So I believe that we have a resource that is very important to it. Perfectly, Doctor. Yes, Dr. Let's just say, pandemic evidenced many difficulties in technological, especially in the elderly, many countries like Colombia, keeping in mind the limitations that there can be in using virtual technologies and IT for providing care by a group of patients with dementia or their caregivers. According to your experience, doctor, in Quebec, what roles do technologies have in strengthening detection, early diagnosis, referencing, and quality caring these patients from primary care, doctor?
So that's a very, very good question. And so it is interesting to see how with the COVID, we developed this technology, telemedicine, telehealth. And I participated in many evaluations of older patients at home with their caregiver of their cognitive status. And although I think it has a place, I don't think it can replace face-to-face evaluation. Face-to-face evaluation provides so much information that we don't see, that we don't feel on the best telehealth, the best platforms, etc. There's body language, there's interaction between the person and the caregiver, interaction with the physician, interaction with the other members of the team that I don't think we can replace. I think it has a place. I think follow-up visits, for example, can be done by telehealth. I think it has a place in primary care that needs to be targeted. And I think that's what we're learning now that we're coming out of COVID, to how we're going to use telehealth and I would say teleeducation in general. And you know, this is fine, this meeting that we're able to do with people all over Latin America and some people in Europe and North America is wonderful because it brings us together. But it doesn't replace us coming together, speaking to each other, all the corridor discussions that go on, all the informal discussions that go on. So we have to learn, I think, the place for telehealth, telemedicine, telemeetings, etc.
fully compare. We have to use all the tools, online and offline, to try to get even to the dispersed rural areas. Well, Dr. Carreño, now we have a big competition, and it says, how can we formalize? How can we formalize the role of the caregivers and institutional caregivers with the social security system? Are we still thinking that we wish to take away the work of the assistant nurses? So this role that's a bit ambiguous that still we have been working on for more than 10 years in the country, we don't manage to have a fundamental role. That's one of the questions. The others are, how does the caregivers program articulates with the district system or the national system, and how we from clinic and centers actually tie into your program that you carry out at your university? Well, there is a debate, yes, in respect of formalizing caregivers with the titles of caregivers. Really, what we have had to live in the universities is that we have family caregivers that don't have the interest many times of getting a degree. We have some assistant nurses that actually the same time are caregivers. So say that we as university have not managed to actually mediate very much part of this debate, because interest is not to award a degree for work, and we can't do it as a university because we only give professional degrees, but rather it is actually a program that provides support to caregivers, to family caregivers. So that's why for our programs is one of the criteria is actually to be a family caregiver. We are not informal caregivers, or we're not assistant nurses or technicians. Let's just say that somehow one way in certain institutions have thought of this, perhaps it can be more economically to cover the care with technical caregivers or assistant nurses that are trained to be caregivers, but it's not been our subject of research. So I do not have the data to claim that we have, degrees for caregivers. For now, the evidence has showed us that in the environments of homes, there are many caregivers that require support. And I think that has been the focus of our acts or actions. For our program, Caring for Caregivers, you can actually come to the group www.chronicle.unad.edu.com. I'm going to leave it in the chat written, and there you have a section for caregivers, and there we can have access to a form of pre-inscription that will come so that you can join to our program. And aside from this, we have the YouTube channels Caring for the Caregiver. We also have transmission there Tuesdays at 6 p.m. And then we have there how do IPSs can they, the institutions actually there, you can write us to our email, and we can coordinate meetings to see how we can tie there. So we actually many IPSs in research or extension according to the need. The IPSs will coordinate it. Our interest is actually to improve the conditions there of family caregivers in Colombia, and any that actually points there, welcome it is for us. We are more than willing to provide support. Perfect, thank you very much. And then we have many people connected, and then we're very happy to have here the webinar, and then to give a step there to the persons that are connected. And raise your hand. I want to interview. So we're going to start with Rosario, and we're going to we'd like to start with your question. What is your question? Rosario is disconnected. So then we have to take my bed. Then the neighbor will mind since we're going to get to this here now. But you have your data raised. Well, thank you very much. Guillermo, I am the sub-director of medical research of this Good Samaritan University. Over and beyond this more successful contribution that you can implement of how the work is done. Intake there, there's some voices coming in and going. As you mentioned in your chats, the integration of the caregivers is fundamental. Here, academia has a protagonic role. We did an experience in with the elderly at Rosario University. Currently, we're doing it there with two universities in Zipaquirá and in certain municipalities of Zipaquirá. And what is the idea, or how have we done that? We've actually brought the university, the faculties, medical specialty, family doctor, to actually bring it closer to municipalities. We do characterizations of the population. We work with the elderly, with adolescents, with all the areas, but in this one particularly we've done it with adults and the educational faculty has a very interesting component for caregivers and for the elderly. One of the topics that we're looking at is to find some students that are working in the field. This results over and beyond as simply as someone would say, we're not inventing it. Simply, we're just saying that at the end of the day, we have some results that will be published that are actually statistical results and that they impact the population. We simply take the guidelines of the province, the ministry, and we see family medicine, and they have the primary layers of the community. With Rosario University, we're doing it in 2 more universities, and the idea is that we get to groups. The student is actually setting and intervene. I'm having sound problems from him. And they do not because they cannot be isolated or so on. So they do follow up, and there's, excuse me, Mr. Leon, your audio is degraded. Your audio. I don't know if you could adjust your microphone because we can actually provide support, but we have degraded audio. Let me see how I can correct. Do you hear me? Now I can hear you well. Yes, now we right there, good. So I don't know at what point, but there's actually what I'm saying, what is important to summarize is intervention of academia here is fundamental, I would say, because of successful experience that we had in Savannah, and we did it with universities, among them Rosario University. And we work with adult communities, and we focus ourselves firstly in the preservation of historic memory of the municipality with the elderly, the adult population, and then secondly in their care, in what we work in the day houses with activities for them from the standpoint of health, psycho-emotional, and of course of preserving a historic memory. And from there to have certain products that are research projects that were actually publishable and that they can have results from the very same policies of health of the ministry. And then we're having in the medical programs to work in the field. How do we manage to do that? We took students, resident students, we take them to hamlets, we characterize the populations, and we started to work in the different groups. In this case, the elderly. We went to their houses. In those municipalities, they have those houses to care for the elderly, and we did activities with them there. And students used to join there. They would know the reality of their country, and they would have to have products of that as a result of that public document that could actually have an impact in the community. And that is how we extended it to Zipaquirá. And we go to marginal boroughs of the municipality. We take nursing students, medical students, psychology students, anthropological students. And as a matter of fact, one of these programs was applicable in the Netherlands. And today, we are sending a group of students to the Netherlands, Yolanda, Holland, to the Netherlands. And they did that the project, and they left a product. They actually work in San Cayetano, and they worked in Cogua, and the hospital network of the Good Samaritan. And they had to project that a work that we actually can give continuity to the of health and in the municipality. And we worked with the mayor's office, with the secretary of health, and then we gave continuity. So these experiences from tying the academia is actually very interesting, because first, they actually prevail in TAME. Second, they're not isolated breeding, because that has no impact on the population, because it's just there. It should continue so that student groups continue to come and to come and to come and to give continuity, and they get more involved in universities in this. It's spectacular. And these experiences need to be worked on. And they have to do it for some time. So it is a proposal. And the Good Samaritan is ready to do them, because we are doing that. From academia, we can continue to do so. And we have already met with the Association of Community Leaders. They are interested. They want to continue to receive our support. But of course, the first component is education component. It's simple. It's actually there. And we actually train with specialists. We train what we call there's the health promoters. Today, they are the health teachers, trained, coached without any cost. Only that academia just does it. The university does it, and the researchers done it. So it's that. And that can be done, and it is being done. Thank you very much. Welcome. For the Samaritan, the Good Samaritan Network of things, it's our pleasure to provide support. Thank you. Spectacular, Doctor. I think that all the successful experiences, we have to show them not nationally, but we have to show them internationally. Right now, after 17 years, Colombia is now host the COMLAT Congress, American and Caribbean Congress, Gerontology, and from the 17th to 20th of May in Medellin, where we're going to have all these successful experiences of all the countries of Latin America and the Caribbean. We're going to show all these models of care. Not only that, but the public policies, how to intervene so that financially this actually can be done. And here we actually bring a question for Dr. Chavarro in this aspect. Doctor, there, what strategies have we adopted financing this type of policies and strategies locally, out of the typical use of a stamp or food stamps for the elderly, increase these resources to be able to greater impact? Well, Dr. We have resources for the different programs with our own monies of the provinces, important ones from the province, and the governor is sensitized and is aware of this type of people, and also with the general system of participation, which are monies there that we have, which are good sources of finance. Perfect. Thank you very much. There are other hands that are there, because now we actually have to start closing this beautiful meeting here. Yes, we have Ines, this Lucy, also with the microphone enabled. Please. Good afternoon. Greetings to everyone here. These venues are very important to guarantee the rights of the elderly. But within that population of elderly, there's a population it's the disabled elderly. That population still is with some life conditions that are very low standard. And the existing laws are not enforced in the, especially in the most area, the rural areas. What can be done with disabled elderly that is unprotected in spite of having some laws are not applied and that they don't have economic resources to implement a public policy of impact towards the improvement of the quality of life? Thank you for allowing to pose the question. Well, once again, I'd like to say thank you to the great number of participants here. Actually, they're great ideas that we have to work in each one of our working sites and the models that we have to implement, from the prevention, the early detection, the management, the mitigation of the impact of everything that can alter our quality of life all day. So thanking everyone of all these, of our great guest speakers. I'd like to give the word for Mr. again for him to close officially because we have limited time. I think we have exceeded ourselves. So thank you very much, Dr. Ramos, for your excellent model. Thank you very much to our guests for having shared their know-how, their knowledge, their experience, this knowledge that they possess that many times cannot be found or compiled anywhere. I want to also announce that the webinar is recorded, so it's going to be able to be seen through the website www.saludderecho.net. You can see it for those who take notes. Is actually have the presentation of our guest speakers there, and we will be producing there some language that will be gathered by the key messages, so that you can have that knowledge. So thank you very much to all, and I also want to thank the assistant members and to the team from the World Bank, Salud Derecho, Oscar Bernal, Janet Bonilla, Julia Rodriguez, and Carlos. And once again, to remind you that we're here to help transfer knowledge. And we will be seeing us in future. It's been a pleasure to be with you. Thank you very much and good afternoon.